Part 2. Alrighty. So, let's talk about rhythms now. First one we're going to talk about normal sinus rhythm. And essentially, everything that you're going to look at is going to be normal. So, is your rate going to be normal? Yeah, it's going to be somewhere between 60 and 100. Is your rhythm going to be regular? Yes. Are you going to have P waves? Yes. And are they all going to look the same? And are they going to be upright? Yes. Is your PR interval going to be normal? Yes. Is your QRS going to be normal? Yes. So what have you done? It's normal sinus rhythm. So what do we do for it? Nothing. We say, thank you, God, and move on. You know, there's enough stuff in the world you have to worry about treating. You don't have to fix what ain't broken. So for normal sinus rhythm, there's not a whole lot to do. Okay, how about this one? If this is a 6-second strip, what's my heart rate? What? My heart rate's around 40, isn't it? Well, that tells you right away there's an issue. Do most people tolerate heart rates of 40? No. So, should there be something in your little head going, mm-mm? You know, I call it my prairie dog. Whoop. There's something going on there. Now, is it regular?
Yeah.
Yes. Does it have P waves?
Yeah.
Yes. Do they basically look the same? Yes. Are they upright? Yes. So where are they coming from?
SA nodes.
Probably the SA node. So if they're coming from the SA node, your first name on this rhythm is going to be sinus. Your last name is going to be bradycardia, simply meaning that it's a rate less than 60. Now, the deal here becomes important when you start looking at this to look at the patient. Because one of the things you really need to learn is that you don't want to be treating the paper, you want to be treating the patient. So you look at the patient, and if the patient is awake and alert and warm and dry and says, no, I don't have any chest pain, I don't have any shortness of breath, I feel absolutely fine, and their blood pressure is fabulous, then guess what? Don't do anything. Because they're not dead, kind of dead, nearly dead, or seriously dead. So you don't got to do anything. There are people who walk around with heart rates that are less than 60 all the time. One of the best examples is Lance Armstrong. The man's resting heart rate is 38 beats a minute. He doesn't need a pacemaker. He needs food. The man wastes lettuce, for crying out loud. I mean, seriously. The man only has 8 fat cells on his entire body, and none of them speak to any of the other ones. So he can make his heart beat 38 times a minute and get enough oxygen. He's got enough contractile strength in his heart to move that blood everywhere from his nose to his toes. I, on the other hand, if my heart rate drops to 38, I will be laying on the floor. Go get help. Because I'm going to be sick. So with sinus bradycardia, usually the only time we get involved or start worrying about it is if the patient has symptoms. Okay? The next one is heart rate of greater than 100. First name now. Is it regular?
Uh-huh.
Yep. Does it have upright P waves?
Mm-hmm.
Do they basically look the same?
Mm-hmm.
So my rate is greater than 100. It's regular. I've got P waves. They're upright. They all look the same. Where are they coming from? SA node. So my first name is going to be? Sinus. My last name, because my rate is greater than 100, is going to be tachycardia. Now, the most important thing for you to understand about sinus tachycardia is that sinus tachycardia is always a compensatory rhythm. There's something going on that's causing their heart rate to be greater than 100. Now, in some cases, it's a medical condition, like, for example, hyperthyroidism. In other cases, it may be environmental. They were doing coke or meth. Okay? They've been exposed to toxins. They have been stressed out. Their 15-year-old just stole their car and drove it into the pool. The insurance company isn't going to pay for it unless they charge their 15-year-old with Grand Theft Auto. You think that's enough to make their heart rate go above 100? Nuh-uh. If they've got a fever, if they're in pain, if they're anxious, you've got a patient sitting in a room waiting for their doctor to come and give them a result of the biopsy that they did yesterday. You think that patient might be just a little bit tacky? Yeah. So here's the deal. If they are tachycardic, what you need to do is figure out why. Because if it's something I can fix, they have just pounded down 5 Red Bulls. And I need to do patient education about not drinking 5 Red Bulls in a row. They used to have this stuff that, thank the good Lord, they've taken off the market. It was called, was it Cuatro Locos?
Yeah,
Four Locos?
Yeah.
Mm-hmm. That was a combination basically of Red Bull and booze. Oh, there's a good combo.
It's still on the market.
Is it still on the market?
They took the caffeine out of it.
Oh, heaven help me.
They just took the caffeine out.
Mary just,
For logo.
I'm going to put my fingers in my ears and go la 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 la. Because it kills people.
Just call it.
He's looking at me going, I'm here, aren't I?
It's cheap bugs.
Oh, God help us all. Yeah, that's what they said about bath salts, too. So, trust me, that's a whole other lecture you want to come to. I have a lecture that I call Street Smarts that includes street drugs. And trust me, the stuff people are putting in their face just makes you go, what? It makes you go, why did you do that? I know. Oh, okay. You're a DAB4. You know DAB4s? Dumb as a bag full of rocks. DAB4. DAB4.
It was all for a little buzz. He did it for the right reason, right?
The big thing to understand here is that there are some things you can fix. Some things you can fix with education. Some things you can fix with. I've got a nurse that I work with that she couldn't figure out why her heart was racing. She'd have these SVT episodes in the afternoon, and I found out she's drinking 3 Mountain Dews a day.
Oh my God.
Like, hello. That's like caffeine on steroids. Making a little heart go, ah. So the big thing to understand is that if you've got a patient who's got a sinus attack, you want to go down and try to figure out what's causing it, because sometimes it's something we can fix, and sometimes it's not. If you've got a patient who came straight out of the OR and they're a little bit tacky, and I don't mean a heart rate of 160, 170, 180. I'm talking about somebody who went in with a heart rate of 76, who comes out of OR with a heart rate of 110. What do you think the problem is with that? One may well be they're a little dehydrated. They've been NPO for 12 hours before they went into surgery. And then the surgery took 4 hours, and the PACU took another hour. So they haven't had anything to eat or drink in 16 hours. You think they might be just a tippy-tad dry? And if they're over 65 years of age, one of the studies shows that 65% of people over 65 are chronically dehydrated. So if you kept them NPO for 16 hours, they're already in probably moderate dehydration. And one of the ways their body's going to try to show it is by sinus tach. Atrial tach. Now, the only difference between a sinus tach and an atrial tach is, number one, if you look at this, is it greater than 100? Yes. Is it regular?
No.
It's really off a little bit. Most of the time, atrial tach is a little bit irregular. But the other thing is, do you have P waves?
No.
Yes, you do, but they don't all look the same. So I got a reindeer, a witch, a pumpkin, and a Christmas tree here. I got an impulse coming from the SA node maybe, but I also have one coming from this cell, and maybe this cell in the atria. I got ectopics firing. So I have a tachycardia. It's still coming from the atria because my QRS is still nice and tight. And a lot of people walk around with atrial tach or atrial rhythms and, atrial fib, atrial flutter, those kind of things. And they do okay with it. The problem, again, is if their heart rate is too fast and they are symptomatic, what do you think you need to do? Slow it down. If they're stable, we can try medications to slow it down. If they're unstable, we're going to treat them with tincture of Florida Power. Zap. We're going to zap them to try to cardiovert them in a lot of instances because we need to get the rate down. And one of the reasons is a real simple one, and I'm sure that you went over this when you were doing your anatomy and stuff, but here's one of the big concepts to remember. Systolic portion of your cardiac cycle is 1/3, diastolic is 2/3. A lot of people learned that diastolic was considered the resting phase. Well, there's no resting going on. You're working hard throughout the whole thing. The problem is that as your heart rate speeds up, your systolic portion really can't shorten by very much. It doesn't have a whole lot of room there. Your diastolic, on the other hand, does. It shortens dramatically. And the two big things that happen during diastole is, number one, that's when your heart gets its blood supply and oxygenation. And that's when your ventricles fill. So if I take a diastolic phase cycle that's this long and shorten it to this long, because my heart rate's 160, what do you think happens to my ability to fill my ventricle? It goes down. Now, I may try to compensate for it by adding a little extra atrial squeeze, but the other thing that happens is my oxygen supply to my heart goes down. So what do you think happens if I make my heart work harder and it demands more oxygen, but I'm supplying it with less?
It's gonna get tired.
That's one of the three ways you can have a heart attack, is having your oxygen demand exceed your ability to supply. So a lot of times when you're dealing with these patients that have very rapid heartbeats, you need to get them slowed down, because one of the things that can happen to them if we don't treat it effectively is they can end up creating an ischemic situation, and if their ischemia isn't fixed, they can end up infarcting and having an MI. Okay? Now, the next two rhythms I'm going to talk about are atrial fib and atrial flutter, and I have a story that I tell for this one. So just kind of relax for a second, because here's the deal. I had a patient that I was taking care of in the emergency room, and in the bed next to my patient was a gentleman who had come in as a new onset atrial fibrillation. And I heard the person that was taking care of him come in. Notice I didn't call her a nurse, because there are people who are nurses and there are people who work in nursing, and they are not the same thing. And when she walked in, he said, I don't understand what they've been talking to me about this fibrillation stuff. I don't understand it. She said, well, the top half of your heart's not working anymore, but the bottom half still is. So as long as it keeps working, you'll be fine. I'll be back later. And she left the room. And I'm standing on the other side of the curtain thinking, that just sucked. And I'm trying to decide, do I want to mind my own business, which anybody who knows me knows that wasn't considered for very long. Do I want to go find her and say, your explanation of AFib sucked, go back and do better, or do I want to just go over and talk to the guy? Well, about that time, his wife comes in. She says, well, George, what have they told you? He said, well, the top half of my heart is dead, the bottom half of my heart is dying, and they don't know how long I have. And I'm like, well, I can't waste time going and finding her, so I whip around the curtain. And I said, wait, time out, George, time out. We need to do a little education here, okay? I said, do you like sports? And he looked at me like I had lost my mind. He's like, and I could see the little wheels in his head going, I'm fixing to die any second, and this chick wants to talk sports. He went, yeah. I said, you like baseball? He went, yeah. I said, okay, here's the deal. I want you to visualize your heart like a baseball diamond. And your SA node, which is a special set of cells in the top part of your heart, is like your pitcher. And it throws an electrical impulse to another special set of cells in your heart called the AV node. He's like the catcher. And once he gets a hold of it, then he's going to fling it on to first base. And when the first baseman catch it, the heart squeezes and blood gets pumped out. So in a normal situation, what you've got is SA to AV to bundle of his blood out. SA to AV to bundle of his blood out. Pitcher, catcher, first base, blood out. Pitcher, catcher, first base, blood out. Got it? He went, yeah. I said, okay. You don't have that. What you have is you have somewhere between 300 and 700 pitchers all throwing balls at the catcher at the same time. Now he's good, but he can only catch so many. So what's going on in your heart is this: pitcher, catcher, first base, bloods out. 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 Got it? He went, yeah. I said, now, as long as your catcher just catches what he can and doesn't try to keep up with your pitchers, you're going to feel fine. Because 85 to 90% of the filling that takes place of your lower chambers, your ventricles, takes place when your valve opens. Just plop. 85 to 90%. So you won't even notice it as long as your heart rate is normal. Now, if your catcher starts trying to keep up with the pitchers and catch them all, what's going to happen is you're going to feel crummy. You're going to get lightheaded and dizzy and maybe sweaty, and you'll have chest pain and shortness of breath, and you'll feel like your heart's trying to pound out of your chest. You're going to feel crummy. And what you need to do when that happens is come in, let us give you some medication, tell your pitcher to sit down and relax, and you'll feel fine again. And he went, oh, okay. I said, people live with this for years. He went, oh, thank you very much. I said, now, you have one other thing that's different about your heart. Everybody else in the world, at the end of the plop, when the blood drops from the top chambers to the bottom chambers, has a little squeeze, woo-hoo, to kind of top off the tank. You know, like putting those extra clothes in the suitcase right before you shut it. That little, or when you're filling your gas tank, and it stops at $46.22, and you go, ibby, to kind of get it up to the next buck. Or in these days, it's just, ibby. But I said most everybody else in the world, when their valve opens and the blood drops down, the top chambers go woohoo and kind of squeeze to top off the tank. He said, okay. I said, yours doesn't do that. Yours does this. It just quivers. But you're going to get 85 to 90% of the filling anyway, so you don't care. Now, if your heart rate speeds up, how much your heart depends on that little extra squeeze goes up as well. So that if you've got a heart rate from 60 to 100, that atrial kick or atrial systole only supplies you with somewhere between 10 and 15%. From 100 to 120, it supplies you with about 20%. From 120 to 140, it supplies you with about 30%. From 140 to 160, it supplies you with about 40%. And greater than 160, 50% of your intraventricular filling comes from that atrial systole or atrial kick. And since you don't have that, if your heart rate speeds up, you're going to feel really crummy. So you need to come in right away and let us take care of you. And he went, oh, okay, cool. I said, people live with this for years. He said, oh, okay, cool. So I go back around my side of the curtain, and I'm minding my own business, and I hear his cardiologist come in. And they said, well, George, what have they told you? He said, they told me I got too many pitchers, but as long as my catcher doesn't try to keep up, I should be fine, and I've lost my woohoo. And I'm on the other side of the curtain going, oh my God, 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 oh my God. And he says, the doctor said, excuse me? And George said, well, I can't explain it. Go around the curtain and that fat nurse will explain what's going on. So now I'm running through the list of cardiologists going, please not him, please not him, please not. Oh, he'd be okay, he'd be okay. And when the cardiologist came around, it turned out to be a really, really phenomenal young doctor named Dr. Francisco Santos, who died way, way too young of pancreatic cancer. But when he came around the curtain, he looked at me and goes, oh, it's you. Okay, I gotta hear this one. So I told him just like I told the patient, and he thought about it for a minute. He goes, that's pretty good. Can I use that? I said, sure. And about 4 or 5 months later, I had a patient who came in who was an atrial fib with a rapid ventricular response, meaning his catcher was trying to keep up. And when I went in, I said, you know what's going on? He said, yeah, my catcher's trying to keep up with my pitcher, so I came in so you could tell him to sit down and shut up. And when I went back and looked at the chart, it was one of Dr. Santos's patients. So it's a real simple explanation, but the only difference between atrial flutter and atrial fib is how many pitchers you have. In atrial flutter, you have somewhere between 150 and about 300. And because the atrial depolarizations are slow enough, the machinery can pick them up, and it shows up like a picket fence or sawtooth pattern. They don't call those P waves, they actually call them flutter waves. In atrial fib, on the other hand, you have somewhere between 300 and 700. And you have so fast an atrial depolarization pattern going on that the machinery can't even keep up. So what you get is a wavy baseline with no clear-cut P wave. And this is your first rhythm that has no discernible P waves. And the other thing about atrial fib that is unusual is that it is always irregular. So you're looking at this rhythm and you say, first thing is, what's my rate? You figure out your rate. Then you say, am I regular or irregular? Irregular. Do I have P waves? No. You're now down to 4. Atrial fib, SVT, junctional rhythm, or ventricular. And one of the things that I gave you is I gave you a couple of Linda cards today. I gave you a yellow one, and on one side it has your heart blocks, which we'll go through in just a few minutes. But on the other side, it has literally a way to look at the rhythms. And if you look in the bottom corner, it actually has the 4 rhythms that don't have P waves. Okay, so what do you know about atrial fib?
Irregular.
No discernible P waves, and it's always irregular. Am I not recording?
I don't know. That would be very
I don't know.
sad, wouldn't it?
We'll just have to do it again otherwise.
Can we start over? Part 2? No, I'm just
Part 2.
kidding. Why is it not showing?
Okay? Now, the next rhythm we're going to talk about has 3 different names. This is Frederick, Freddie, and Bubba. It's all the same guy. It's SVT, which is supraventricular tachycardia. It's PSVT, which is paroxysmal supraventricular tachycardia, or PAT, which is paroxysmal atrial tachycardia. It's all the same guy. And here's the deal with this one. You ready? You come to my house, you knock on my door, and behind the door you hear this. Woof, 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 woof. What do you know? I have a dog. What kind? You don't know. You haven't seen it. Right? Well, until I open the door and you can actually see my dog, you don't know what kind it is. Well, I know by looking at these QRSs, which are nice and tight and narrow, that the impulse is being generated from above the ventricles, because if it was starting in the ventricles, it couldn't get on that AV node ventricular conduction pathway. It's like driving in Orlando trying to find an entrance to I-4. You can't get there from here. You can see it, you just can't get on it. Okay? So the thing is, with this one, just looking at this rhythm, the very first thing I note is that the heart rate is fast. And with SVT, the rate is greater than, it's 150 or higher. The second thing I notice is it's pretty regular. Third thing is, do I have P waves? Well, I have some people who say, well, I think that's the P wave. Well, if that's the P wave, where's the T? It's got to have both. Now, it may be the P wave and T wave are combined together, but you don't have clearly discernible P waves. So this is your second rhythm with no P's. But how do I know that it's coming from above the ventricles? Because my QRS is nice and tight and narrow. So anything that's coming from above the ventricles would be called supraventricular. That's all. It's just a basket term. Now, if I give this guy medication, or I do vagal maneuvers or carotid massage or other things to try to slow him down, and I slow it down enough that I can actually see the P waves, and all the P waves were upright and the same size and the same shape, what kind of tachycardia would it be? A sinus tach. If they were a little bit irregular and the P waves were different shapes and sizes, it'd be an atrial tach. And we'll talk about junctional rhythms in just a second, because if they were inverted, it'd be a junctional tach. So the deal here is, until you can slow it down to see the P waves, you can't tell where exactly it's starting. But you know it's starting from above the ventricles, hence the term SVT. And the problem with SVT is because the rate is greater than 150, most people, even healthy people, don't like it much. It feels weird. It feels like your heart's pounding out of your chest. It makes you feel lightheaded and dizzy. Your older patients will say they have the V and Ds. I'm so weak, I'm so dizzy. And the problem is, again, if I'm shortening that diastolic portion, and I'm making my heart work harder but giving it less oxygen, I'm setting it up to develop problems. Now, it's a 22-year-old heart that's perfectly healthy and the fibers are great. They can probably tolerate an SVT for a little while. If they're 65 and they have ventricular hypertrophy, they're not going to tolerate SVT for very long. They're going to get sick, they're going to get ischemic, they're going to infarct, and they're going to die. So this is something that if it's unstable, it needs to be treated really quickly. If it's stable, you've got a little bit of time. Stable meds. What kind of meds? Well, the nice thing with the narrow complex SVT is you got a whole menu you can choose from. You can try adenosine, you can try beta blockers, you can try cardizem, you can try amiodarone, you can try DIG. It's an oldie but a goodie, but it works. But you've got a lot of different choices, or the doc does, to try to slow it down. If it's a rapid AFib flutter, they're more likely going to try cardizem because that works well on an AFib A flutter that's going too fast. But this one, the big thing is you want to know, number one, do they have a pulse? And number 2, are they stable or unstable? Because whether they're stable or unstable is going to determine how you treat it. The next 2 I put together as well, and that's sinus pause and sinus arrest. And here's the deal. I want you to just watch me. Put the paper, watch me. Here's the deal. I would be willing to bet you that when you went to bed last night, the last thought in your head wasn't, gee, sure hope my heart keeps beating all night. You kind of count on it doing that. We count on the SA node firing. That's what its job is. Well, in both sinus arrest and in sinus block, the SA node fails to fire. So it's like this. This is my SA node firing, and this is my ventricular response. Oh, sorry. Now, the only thing that determines whether it's a sinus block or sinus arrest is when the next beat shows up. Because if it shows up on time, like it didn't miss any, then it's a sinus block. If it shows up outside of that range, it's a sinus arrest. So let me show you. Ready? Did it show up on time? Showed up right on time. That's a sinus block. You ready? You can say it showed up a little early, or you can say it showed up a lot late, but it didn't show up when it was supposed to. That's a sinus arrest. Now, what's the problem with both of these? I suddenly have an SA node that is supposed to be my natural generator, and it's not generating regularly. Whoops. So guess what? The treatment for this is going to be a pacemaker. Not to completely replace it, but to be in the background to say, okay, if you don't fire, I'm here for you. I'll be your backup system. So that if I'm watching you and you're going, boom, I'm going to fire if you don't. So I'll be there to help you. I'll be your backup. And the only difference between sinus block and sinus arrest is when the impulse shows up. So how do you figure it? Well, you measure the distance between the R waves, and you say, I should have had an R wave here, I should have had an R wave here, I should have had, oops, it showed up right where I was supposed to. That's a sinus block. Should have had an R wave, should have had an R wave, should have had an R wave, whoops. Where my arrow is where my QRS should be, and it came in before that, so that's a sinus arrest, and that's the only difference. And the treatment is a pacemaker.
Is it a pacemaker for both?
For both of them, yep. Now, this last one is what's called a wandering pacemaker. And this is a really old term, but it still gets thrown around every now and then. And essentially, if you look at this, first thing you want to say is the rate okay? Yeah, it looks okay. Is it regular? It's pretty regular. Do you have P waves?
Sometimes.
Sometimes. And do they all look the same? No. So if you look, that P wave doesn't look like the second one, which doesn't look like the fourth one, which doesn't look like the sixth one, which doesn't look like the seventh one. And all you have to have for a wandering pacemaker is 3 or more different sizes and shapes within that 6-second strip. And the deal here is very simple. It's like you have you got a crowd of people, and they all want to be the boss. And if they're sharing the responsibility, everybody's a happy camper. But if all of a sudden it's like, well, you're not doing it, so I'm not going to do it. Well, if you don't do it, I'm not going to do it either. Well, I'm not going to do it either. All of a sudden you got nothing, honey. So again, with wandering pacemakers, generally they'll put in a pacemaker to serve as a backup just in case everybody decides to go on strike at the same time. PVCs, or PACs. These are just premature complexes. If you've got a friend who's going to have a baby in August, and she calls you up the 1st of July and says, guess what? I had my baby. The only thing that is different about that baby is it came early. Might be a little smaller than usual, but it's got all of its pieces and parts. Well, a PAC has all of its pieces and parts. It just comes early. And the thing that differentiates, you can have a premature atrial complex, a premature junctional complex, or a premature ventricular complex. The only thing that differs is in the PAC and the PJC is the P wave. Do you see a P wave? And if you take a look at that first beat And then you see the second beat that comes early. Does it have a P wave? Yeah. Is it upright? Yeah. So if it's an upright P wave, where's it coming from? Someplace in the atria. So it makes it a premature atrial complex. Now this is where it can get a little confusing. So hang on to your seats for a second. Let's take a look at this one here. I got a P wave, a QRS, a T wave. Then I got another QRS, but I don't have a visible P wave here. So I don't know if this P wave is absent or if it's there but just mushed in with the T wave. So what I do is I compare the size of this T wave to the size of this T wave. And what do you see about this T wave? It's bigger, so it's got more energy. You've got the P wave standing on the ground and the T wave standing on its shoulders. So it makes the whole thing look bigger. So that means you've got an upright energy there. So that makes it a PAC. Let's talk heart blocks. Junctionals. Here's the thing with junctionals. I need a little person.
Me?
No, behind you.
Not me.
Yeah. Come here. I need a visual aid here. Okay. So this is the deal. She is my inverted P wave because whenever you have a junctional rhythm, you have an inverted P wave. So in some instances, move around on this side. I'm going to have the inverted P wave before my QRS with a nice narrow QRS. Okay, inverted P wave, you know it is junctional. Sometimes, move to this side, I can even see this inverted P wave after my QRS but before my T wave. It's kind of like wonking in the middle there. But here's the important one, behind me. Sometimes it occurs at the same time as my QRS, so you don't see a P wave at all. So, thank you very much. You were a lovely P wave.
Inverted.
So here's the deal. Sometimes, see if I can do this without falling on the ground. With junctional rhythms, anytime you see an inverted P wave, it's junctional. But sometimes you don't see the inverted P waves. You don't see any P waves at all. So this is rhythm number 3. Now, I'm going to be topical. Joe Biden doesn't want to step on Barack Obama's toes. So he has an intrinsic rate that is lower than the SA node. Because if it is a junctional rhythm, it's being initiated in the AV junction. I trained in Michigan. We call them junctionals. Down here, they call them nodals. I think it sounds more southern. He's got a nodal rhythm. Junctional sounds more Michigan. Nodal is the south. So the deal here is this. The intrinsic rate of the AV node is less than the SA node. SA is 60 to 100. The intrinsic rate of the AV node is 40 to 60. Can it go faster than that? Yes, it can. But normally it's going to be somewhere between 40 and 60. Is it regular? Yes. Does it have P waves? If it does, they are inverted or they're absent. But how's your QRS look? It's starting in the AV node, so it's going down the ventricular system normally. So your QRS is going to be normal, nice and tight and narrow. Well, what if it's faster than 40 to 60? Oh, I'm sorry. This is my one that shows you the before it, none, and after it. Now, I've had some people say, Linda, I have to tell you very honestly, I don't think I would notice the one that was after, and I said, that's okay. Because if you don't notice the one that's after, you're still going to say that it's absent. So you're still down to 4 rhythms that don't have P waves. What's the difference between an atrial fib and a junctional rhythm? They both have narrow QRSs, but one is irregular and one is regular. Third one is SVT. What's the rate on SVT?
150.
At least 150. It's very unusual for you to see a junctional rhythm go greater than 150. Okay? Well, what if it is greater than 60? But it's not as fast as 100. Because anything greater than 100, we're going to give the last name of tachycardia. But what if it's a junctional rhythm that's in the 70s or 80s? I have to have some way of letting you know that it's faster than normal, but not fast enough to be a tachycardia. And so what I do is I just add the word in the front, accelerated. And the way to think about this is if you want your car to go faster, what pedal do you step on? Accelerator. I have people say the gas pedal. No, accelerator. It's just an accelerator or faster rhythm. Now, how do you think the patient's going to look if their heart rate's this? Fine. Do you have to do anything for them? No. Most of the time, junctional rhythms are transient. They go away. They go back to sinus rhythm. Everybody's a happy camper. What about this one? My heart rate's greater than 100, so my last name is going to be tachycardia. What do you notice in front of those P waves? Or in front of those QRSs? Inverted P waves. Anytime you see an inverted P wave, it is junctional. So my first name is junctional, my last name is tachycardia. Now, most of the time for junctional tach, your junctional tachs don't get more than 120, 130, 140. Occasionally they will. I've seen a junctional tach at 180. But here's the deal. Let's say you've been taking care of the patient all day long. They started out in a junctional rhythm. At 1 o'clock in the afternoon, they became junctional. They did an accelerated junctional. They don't have any P waves. But you know it's been junctional. And then all of a sudden they go greater than 100. Guess what you get to call it? Junctional tach, because you've been watching them. But if you just show me a rhythm strip and I don't know anything about the patient, and they've got a heart rate that's greater than 150, nice narrow QRS, or a heart rate that's 130, nice narrow QRSs, no discernible P waves, I'm going to call it junctional tach because I don't know anything about their history. You get to call it junctional tach because you know them. You've been watching them. What do you do for a junctional tach? You look at the patient, and if they're symptomatic, you're going to treat them, and if they're not symptomatic, you're going to leave them alone. Take a look at that premature complex. What do you notice about that premature complex?
An inverted P wave.
It's got an inverted P wave in front of it. What do you know as soon as it's an inverted P wave? It's junctional. Yep. Now, let's talk heart blocks. Okay. The only thing about a first-degree heart block is that the PR interval is prolonged. It means you've got a delay coming through the AV node, but every single beat is making it through. Everyone is being conducted. Everyone is getting a ventricular response. The only thing that's unusual about this is that the PR interval is long. What do you do for it? Nothing. Why do you care? Because it can deteriorate to something worse. Now, on my little yellow card that I gave you, we're going to talk heart blocks now. So, flip it over to the side that has the algorithm. And the very first statement on the card says, if you have a prolonged PR interval with no dropped complexes, that's a first-degree AV block. What's the next question? Do you have more P waves than QRSs? Let's take a look. Looking at this rhythm, do you have more P's than QRSs?
Yes.
Yes. So go down the algorithm. The answer to the question was yes. So what's the next question? Is my PR interval constant? Is this PR interval here?
No.
Whoops, where'd it go? Yeah. You got a drop complex there. Is that PR interval the same length as the next one?
No.
No. So move down the algorithm. What's the next question?
R to R constant.
Is your R to R constant? Is your R to R constant in that rhythm?
Well,
If you measure from R to R,
you just have drop.
you have to skip over where you have the missed things. Here's your deal. Ready? Whoops. Pardon me. There's my R to R. There's my R to R. Are they constant? No. If your R to R is not constant, it's a second degree type 1. Also known as a winky buck. They stopped calling it winky buck because nurses couldn't spell winky buck. Also known as a second degree type or Mobitz 1. Let's look at the next one. Oh, and this the one that I give you for this one is this. I want you to think about the P wave is the man and the QRS is the wife at home. He comes home. The next night he comes home a little later. Then he doesn't come home at all. You drop the QRS. Now he feels guilty, so the next night he comes home on time again. Next night, not so guilty, so he's a little later. And doesn't come home at all. He's back to it. Or think about it as a bow and arrow. You pull it back, 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 and when you let it go, the bowstring goes back to the bow. Some people talk about this as progressive lengthening of the PR interval. Okay? Let's take a look at this one. Do you have more P waves than QRSs?
Yes.
If you look at it, P, QRST, P, QRST, P, P, QRST, P, QRST, P, P, QRST, P, QRST, P. So, do you have more P's than QRSs? Yes. Then look at where you have both a P wave and an R wave. Is the PR interval constant?
Yes.
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 When you think about a second degree type 2, think about in order for you to be stable, steady, constant, you have to stand on 2 feet. That gives you Roman numeral 2. Okay, second degree type 2. This is the husband who comes home, and when he comes home at the same time every night. And if he's not there by 5:30, he ain't coming home. So the kids are all around the dining table going, we want food, we want food, we want food. And she goes, oh, okay, it's 5:30, eat. Okay? Then there's this one. Do you have more P waves than QRSs?
Yes.
No.
Got it. T wave.
You just saw the
See the bump after the T?
Uh-huh.
That's a P. Then you got another little P. Then you got one buried in the T wave. Then you got another P. You got one right after that QRS. Right after the T wave. See those funny bunky bunks? Yep, you got more P's than QRSs. Next question. Is the PR interval constant? No. Is your R to R constant? Measure from one R wave to the next R wave.
Yes.
It is constant. That makes it a third degree. Now, here's the deal with third degree. The husband and wife, they unfortunately want to get a divorce, but they can't afford to sell their house. So they're both living in the same home. He keeps his schedule. She keeps hers. So if you measure P to P intervals, it marches off. Because on Monday he goes to Hooters. On Tuesday he plays poker. On Wednesday he bowls. On Thursday he shoots pool. On Friday he plays something else, softball. On Saturday, he picks up his kids. Then if you measure the R to R's, her life is marching out too. On Monday, she has bridge. On Tuesday, she has the garden club. On Wednesday, she goes for a spa. On Thursday, she subs at her kids' school. On Fridays, she's got her life marched out. It's almost as if you built a wall between the atria and the ventricles. The atria are firing on their signals, on their schedule, and the ventricles are firing on theirs. And there's no connection between the two. And the problem is that if the ventricles stop firing, what do you have left? You have nothing but P waves, and that is not where you want to be. Okay? What's my heart rate here? It's an oh my God 20. Right? What do you notice about this? First thing, it's slow. Next, is it regular?
Yes.
Yeah. How's your QRS look? Nice and tight and narrow, or big and fat and wide? So if it's starting in the ventricle, it's going to have to go cell to cell to cell to cell to depolarize, so you're going to have a wide QRS. Do you have a P wave there that you can see? No. So all you have is QRS. It's a ventricular rhythm. And the technical name for it is idioventricular. And the way that I remember that is, if the only thing you're depending on to keep you alive is your ventricles, you're an idiot. Idio means I don't know where in the ventricles it's coming from. I just know it's the ventricles. Can I have a rate faster than 20 to 40, which is the natural rate of the ventricles? Yes, I can have an accelerated idioventricular. Makes you feel very medical when you say that. The patient has an accelerated idioventricular rhythm. I can have VTAC. Good news, bad news. Good news is sometimes you have VTAC with a pulse. And you can have VTAC with a pulse and the patient is stable. I had a guy walk in off the golf course saying, I got this fluttering in my chest. We hooked him up to the monitor. He was in VTAC at 240. And I was like, whoa. And I stat paged the ER physician who came in and went, hey, whoa. This is what I call the ooh, hey, hey rhythms. Because if you have a patient who goes into this rhythm on the monitor and somebody sees it, they don't go, oh, excuse me. I just thought perhaps someone should know the patient has started to have ventricular tachycardia. They go, oh, hey, 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 hey. Because unfortunately, they can also have VTAC without a pulse, which means they're dead in the bed. Or as we emergency room nurses refer to it, DRT. Dead right there. Now there's a special type of VTAC that's called torsade de pointe. It looks like torsades de pointes. It's French for twisting of the points. And essentially the big thing to understand about torsades is that this is normally the result of an electrolyte imbalance. And literally what you'll see normally is this pattern where it goes up, 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 and down, 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 up, 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 down, 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 down. But you also can have, that's a classic torsades. You can also have this one, which if you talk to nurses who've been nurses for a very long time, we used to call this concertina. There's a little accordion that the Italians used to play. It's called a concertina. I call it the wah-wahs. Because if you look at it, it looks like it's going. This is torsades as well. And the treatment for torsades is not an antiarrhythmic. It actually is magnesium sulfate. Because it helps to stabilize the cell wall and allows the sodium and potassium transport to improve. Then there's this. That's VFib. The heart is basically doing this. You have no, you ain't spitting out nothing. So has the patient got a heartbeat? No. So you see this on the monitor, you check a pulse, he has no pulse, and the doctor says, get a blood pressure. Take his. Of course, the patient don't got one. Now, you can have coarse VFib that looks like that. Coarse VFib normally occurs within the first 4 to 5 minutes. The good news is if you can defibrillate them when they are in coarse VFib, you've got a 90% chance of converting them with a biphasic defibrillator. Fine VFib, on the other hand, only has about a 20% conversion rate. But here's the good news. If I do 2 really good solid minutes of CPR, I may well be able to convert this fine VFib back to coarse VFib, in which case I can get a rhythm. PVCs, wide and bizarre looking. You can spot these suckers from across the room. If they have the same shape and same size, we call them unifocal. If they are different shapes and sizes, like the first 2 are the same, but the third one isn't the same, we call them multifocal. If they occur together, we call them a couplet. If they occur every other beat, we call it ventricular bigeminy. In the olden days, anybody who was in bigeminy, we'd have them on an antiarrhythmic so fast their head would spin. We don't anymore, because if your heart's been beating 84 years, 80 times a minute, 60 minutes an hour, 24 hours a day for 365 days a year for 84 years, you're entitled to have PVCs. So unless they're symptomatic, we don't treat them. Almost done here. This one is exactly what it looks like. Do you see any ventricular activity there?
No.
What are the ventricles doing? They're standing still. Which means the patient is dead right there. Now, they can try a pacemaker on this because it may be just that they were in a 3rd-degree heart block and the ventricles stopped beating on their own, so they can run a wire into the ventricles and try to stimulate the ventricles and see if they get a response. Sometimes they do, sometimes they don't. But this one isn't going to be a backup, it's going to be a replacement. So it's going to be a timed or triggered pacemaker. This is a serial rhythm. Not in honey. You got no atrial activity, you have no ventricular activity, and less than 0.1% of patients that have asystole ever come back from asystole. There are 3 times you will see asystolic codes work for a long time. One is if they're cold, because the rule is you're not dead until you're warm and dead. You don't respond to the medications, you don't respond to defibrillation, so they got to try to warm you up to get you to respond. Second time is if they're a drug overdose. Sometimes they'll try to dialyze them, try to get the drugs out of their system, and try to keep them alive long enough to be able to do that. And the third time is when it's a kid. Because nobody wants to have to tell their parents their child is gone. It's just not, no, don't want to do that. The problem is that they truly are in asystole. God's won this one. We used to do this thing in the emergency room, and I'm telling stories out of school. And it's this. We'd hear the radio go off, and you'd hear ALS Fort Leesburg Regional, and in the background you'd hear shh, shh, shh. It meant they were on the thumper. We'd say, strike one. We have a 75-year-old male who was found in asystole. We've done 3 rounds of ACLS meds, and he remains in asystole. Strike 2. We've been working this code for 45 minutes. Strike 3. So basically, when they would get to us, we did what we called the holy water code, which was give them 1 amp of epi and then say we're done. Because if they were truly in asystole for 45 minutes, they're not coming out. Last 3 rhythms are pacemakers. Here's the rule. You can have a pacemaker that goes into the atria to trigger the atria to fire. You can have a pacemaker that goes into the ventricle to trigger the ventricle to fire. You can have one in each to do both. But ultimately, what it comes down to is human beings do not make straight lines. So if you see a straight line like this, that's a pacer spike. And what you hope to happen once you've had a pacer spike is to get a response, where you get a ventricular response. We count how many paced beats they're doing based on how many beats out of a minute they're pacing. So if their heart rate is 80 and they're pacing 40 of those 80 beats, then we say they're pacing 50%. If their heart rate is 100 and they're pacing 20 beats, then they're pacing 20%. So that's how we figure that. And the only thing that a pacer can do is either pace the way it's supposed to, or it can fail. And there are 3 failures. This one is a failure to fire. It didn't know that it was supposed to, and it didn't fire. And it can do that because the pacer wire is not connected. Sometimes that happens. It can happen because the patient has an MI where the pacer wire is connected and dead meat. Don't beat. So it doesn't matter if you're stimulating the heart. If the tissue's dead, it won't respond. It can also do it because the batteries are wearing out. You can have this one. Pacer, patient beat, patient beat, patient beat, pump, patient beat, pump, patient beat, patient beat. Should that pacer be firing when the patient's having his own rhythm?
No.
No, this is a failure to sense. It can be because the sensing wire has become disconnected. It can be because the sensitivity is not turned up high enough. Or it can be because the batteries are wearing down. And then last but not least is this one, which is it's firing, but there's no response. This is what you get at the end of a code with somebody who has a pacer in place. You get the spikes, but you don't get any response. This is a failure to capture. So you can pace normally, you can pace and fail to sense, fail to fire, or fail to capture. Them's your failures. And I apologize for going over 7 minutes, but we're done.
No, thank you so much.
And I have to tell you, I'm very sorry, but when we were on break, I took my thing off my neck because it bothered me and I forgot to put it back on. My microphone thing.
Yeah, I'm sure it still picks you up. I'm sure.
So hopefully I spoke loud enough that you got me. And if you didn't, I'll just have to teach it again another time.
There's our
You
little
can go back
thing.
there for the test.
Yeah.
The day of the test.
Sabrina has it on her report.
I'm sorry, I apologize.
Oh, no.
I just looked down and
no.
saw it sitting there, and I'm thinking, whoops. I'm not used to having anything around my neck because I usually talk loud enough that you don't have to worry about it. Okay?
Okay.
Okay. I have been a nurse. I'm celebrating my 40th year as an RN this year. So I've been around a long time. And I talk about the old days and when it was me and Florence and Clara and a few others that were taking care of soldiers in the Crimea and that kind of stuff. So I've been around for a long, long time. And I have had an opportunity as a nurse to really see nursing grow from let me just give you an idea. When I was a nursing student, and I'm talking about in the late 60s, early 70s, we were expected when physicians came on the unit to get up and give them our chairs. Didn't matter what you were doing. You could be in the middle of charting a code. If a physician came on the unit, and he was not even supposed to have to ask, you were supposed to magically know that there was a physician behind you, and you were to leap to your feet and give him your chair. Nowadays, we don't do that. We say, there's a chair over there. Help us out. We had to get them coffee. And I will tell you, my first job as a nurse, I knew how every one of the attending physicians took their coffee. I mean, please. Can you see us doing that now? I mean, I get coffee now for the docs I really like. The doctors I don't like, I spit in it. I don't, Well, no, I don't. That's a lie. I forgot I'm being recorded. Anyway, so what we're going to do today, what Deb, Mrs. Pate asked me to do, was she asked me to come in and talk to you about cardiac rhythms, because this is one of those things that frequently will make people's little eyeballs roll back in their head, and they'll be, I can't remember all that stuff. And it's really, really easy, because essentially what cardiac rhythm identification is it's taking all of these choices and then saying, well, it can't be those, it can't be those, it can't be that, it can't be that, it can't be that, it can't be that. Aha, it has to be that. And that's kind of what it is kind of narrowing it down. And the idea here is you have to know kind of what to look for. So when we talk about, hello? Let's try a different button.
Oh, there you go.
Yay. Okay. When we talk about the cardiac system, oops, I jumped ahead, way ahead. Okay. When we talk about the heart, we're basically talking about a 4-chambered organ. And I want to take just a few minutes at the very beginning here to kind of do a little brush up on anatomy, physiology type stuff. So when you're talking about the heart, you're talking about a 4-chambered organ that essentially serves 2 purposes. Okay. Its first purpose is to act as a collecting point. Okay. The right side of the heart acts as a collecting point of blood that's been utilized and is being brought back to the body. It then sends the blood that it collects into the pulmonary tree to have the gas exchange take place, where CO2 gets blown off and O2 gets picked up. And then it comes back into the left side of the heart, which essentially serves as a pump. So the right atria is a collecting point from the body. The left atria is a collecting point from the lungs. The right ventricle pumps blood from the right side of the heart into the pulmonary tree, and the left side of the heart pumps blood out to the body via the aorta. And let me just give you a really simple way of thinking about this. I want you to think that we are a Pepsi plant. And the right side of the heart is the receiving dock. And what's being brought back are all the empty Pepsi bottles. Okay? The empty Pepsi bottles are brought back in, they're offloaded, they're washed, they're sent to get new Pepsi put in them. Okay? The new Pepsi, once it's put in them, goes to the loading end of the dock. And there it's loaded onto trucks, and the trucks take it out of the plant, and it goes out the entrance from the plant and then goes off on its different roads to go to the various 7-Elevens and Winn-Dixies and Payless and wherever the hell it's going to go. It goes. Okay? So the big thing to understand here is if you think about your heart kind of like a Pepsi plant, you're taking the empties, you're refilling them, and you're sending it back out to be utilized again by the next person who wants a Pepsi. Or in your body's case, for the next person who wants some oxygen. One of the things that happens is in utero, the walls of the right and the left ventricle are about the same thickness. It's not until the baby is born and the left ventricle has to start pushing against a higher level of resistance that the left ventricular wall starts to thicken. And it ends up being able to generate a contractile force, depending on which resource you read, that is somewhere between 6 and 10 times the contractile force of the right side of your heart. Okay, so it has to work very hard. The right side only has to push against the lungs, which are very elastic in most cases, very kind of relaxed. They got a really good compensatory activity. So you're only pushing against a pressure that's somewhere usually between 10 and 20 millimeters of mercury. Where when you're pushing from the left ventricle, you're pushing against a much higher level of resistance that's normally somewhere between 70 and 90 millimeters of mercury. So if I put you in a chair in the wellness center over at LRMC and I give you a 2-pound weight and I say, I want you to do curls until I come back and tell you to stop. And I put your friend here in a chair right next to you, only I give her a 20-pound weight and say, keep up with her. When I come back to you, you will look fabulous. You will be toned and beauteous. She, however, will look like Arnold Schwarzenegger because all of that resistance is going to bulk up those muscles. Well, the same thing happens with your heart. When you think of the right ventricle as the Paris Hilton of your heart. It doesn't like to work hard, and it doesn't like to push against a lot of resistance, okay? The left side of your heart, on the other hand, is your workhorse. It is really the thing that generates your cardiac output to get oxygen from your nose to your toes, okay? So that's like a real brief to-do down there. Are you going to change? Let's try to hit this button. No, that's not working either. Let's try this one.
What did we?
Poof!
How did you get it to work before?
I gotta do it from the clicky thingy.
I guess.
Well, that's kind of silly-ish.
Is
Okay,
that it?
now
Maybe.
I'll smooch it or something.
Or
We'll smooch it.
That won't come off. Yeah.
It's okay, I'll smooch.
Okay.
Oh, ooh, hello.
You actually can just do this on the side.
Yeah, okay, dokie. Okay, conduction, going through the heart. And we're going to talk normal conduction for right now. Starting point is the SA node, the sinoatrial node, and here's one of the things that you can pick up, and that is any rhythm that is generated by the natural pacemaker of the heart, which is the SA node, will have a first name of sinus. So if the rhythm is too fast, it's going to have the last name of tachycardia. If it's too slow, it's going to have the last name of bradycardia. And if it's just right like Goldilocks, it's going to have the last name of rhythm. But if it starts in the SA node, it will have the first name of sinus. Okay? The sinus node is the natural pacemaker. And it's not like if you dissected a heart, you would say, aha, there's the sinus node. It's basically a collection of cells that actually repolarizes faster than their adjacent cells. So it's kind of like the boss guy in most normal cardiac type situations. Now you can have problems with your SA node and start generating impulses in other places in the atria and even in other places in the ventricle. But under normal circumstances, when push comes to shove, most of the time what you're going to be generating from is the SA node. That's your natural pacemaker. It has an intrinsic rate of between 60 beats and 100 beats per minute. It allows the electrical conduction to be generated, and it sends it down through the intraatrial nodes or intranodal pathways. And it's kind of like if you and I decided we were going to go to Tampa this afternoon after class, and you took I-75 and I took the 301. We are both going to eventually get to Tampa, but there's a really good chance you're going to get there a heck of a lot faster than I am. Because hopefully, if there's no accidents on I-75, you're going to be able to kind of go lickety-split. I, however, am going to be going through Bushnell and Lake Pennsauken and Webster and Spring Hill and all those places that go from 55 to 15 in like 12 feet, you know, those kind of places. So I'm going to have red lights and stop signs and hay trucks and, you know, all kinds of stuff that's going to slow me down. I will get there eventually, but I'm not going to get there quickly. When the SA node generates an impulse and sends it down through the intranodal pathways to the AV node, it does it very quickly. And it does it in somewhere between 0.12 and 0.20 seconds. Okay, don't get yourself crazy. It's all in your papers. For those of you that are furiously scribbling, let me just tell you that my handouts are like ragu. If it's important, it's in there. Okay? So trust me, there will be places in the handout where the normal intervals are listed and all that kind of stuff. So just relax. It'll be okie dokie. All right? Now, from the SA node, it goes down the intraatrial pathways to the AV node. I want you to think of the AV node like the doorman at your nightclub. And he's going to be the one who is going to decide impulses, whether they're coming in, whether they are dressed appropriately and they're old enough to go through. And if they are fine, he lets them go through. If, however, he's not quite sure, he may hold them up for a little bit and check their ID. So in some instances, some impulses come in, and instead of being allowed to go straight through the AV node, they're held at the AV node. And in some cases, they're held for a prolonged period of time. And if they're held longer than a normal length of time, we call that an AV block. And in some cases, it just holds them for a little while and lets them go through. In some cases, he holds them and says, oh, please, you're not 28, go home till you grow up. And that impulse doesn't get through at all. And we're going to talk about the heart blocks more in just a little bit. It goes from the AV node down the bundle of His, and down the bundle of His to the bundle branches, and from the bundle branches to its termination points, which is the Purkinje fibers. Now, I want you to think of the ventricular conduction pathway like a slide of Wet n Wild. Once that conduction hits that AV node, and the AV node says, go on through, it's like somebody has opened the door and they drop, and it's like right down that ventricular conduction pathway really, really fast. And one of the ways that you can tell that that conduction is going very fast is when you look at the waveform that represents that depolarization, the complex is going to be really, really skinny and tight. And we'll explain why in just a second. Okay? So, EKG paper. EKG paper is designed so that we can measure things on it. Specifically, the horizontal axis is a measurement of time. And each little tiny baby box is the equivalent of 0.04 seconds. So if I have 2 little baby boxes, it's 0.08 seconds. If I have 3 little baby boxes, it's 0.12 seconds. If I have 5 little baby boxes, it's 0.20 seconds. Now, I will tell you that when I first graduated from nursing school, these boxes were a whole lot bigger than they are now. Because when I look at them, I'm like, what? And I know it can't possibly be me. So they must have shrunk the boxes. That's my only explanation. But one of the things that they've done, if you take a look at my EKG strip up here on the screen, you'll see that for every 5th baby box, there's a darkened line. It allows me to count a whole lot easier than having, let's say, for example, I have somebody who has 9 baby boxes in length for their PR interval. I would have to count 9 of them little baby boxes. And what happens is this. 1, 2, 3, 4, 1, 2, 3, 1, 2, 3, 4, 5, 6. 1, 2, 3. So they put the big lines there so that we don't rip it up. Some of us get a little frustrated. Okay? But the big boxes basically generate every 0.20 seconds. So if I have 1 big box plus 1 baby box, it's 0.20 plus 0.04. So the length of my complex would be 0.24 seconds. So the horizontal axis allows me to measure time. The vertical axis allows me to measure voltage. How strong is my complex? And now, in a lot of instances, you may have people who have had MIs, heart attacks in the past, and they've got dead tissue in their heart. Now, I have what I call Linda's cardiac axioms. These are not written down for you, so if you want to write them down, this is the time to get your pen out. Ready? Linda's first cardiac axiom is, your heart is like your checkbook. You can't put out what you don't get in. So if I don't have good squeeze on the right side of my heart, and I'm not pumping blood from the right side of my heart to the left side of my heart, even if the left side of my heart is fabulous, it can't pump out what's not there. If I'm only putting 25 or 50 cc's, even if I get really good squeeze, the most I can pump out is 25 or 50 cc's, which in the general scheme of things is instead of whoosh, okay? So, number 1 rule is your heart's like your checkbook. You can't put out what you don't get in. Linda's rule number 2 is dead meat, don't beat. So if they've had MIs in the past and they have cardiac damage anywhere along their conduction pathway, it's going to alter their ability to conduct. If they have damage in their left ventricle, it's going to alter their ability to contract. It's going to alter their ability to compensate if they start to get into trouble, because they may have a large amount of tissue that's unavailable to them. And Linda's third axiom, cardiac axiom, is a real simple one, and that is that damage to the heart is cumulative. So if you're in the emergency room or you're on the floor and you get an admission and you say to the patient, can you tell me what kind of medical history you have? And they say, I've survived 5 heart attacks. And you look on their chart and see that they're being admitted for number 6. That should make you go, whoa. And it should make you start to sweat. If you don't sweat on a 6th MI, you obviously do not understand what is happening. Because here's the thing. If they lost 5% with their first MI and 10% with their second and 5% with their third and 10% with their fourth and 5% with their fifth, and now they've lost another 5%, if they reach what's called critical mass, which is somewhere between 35 and 40% of their left ventricular function is diminished, they can go into cardiogenic shock and end up dead as a doornail. So the big thing when you're talking to patients about history is you want to ask the questions they're going to answer. So you ask them about, have you ever had a heart attack? Don't ask them if they've ever had an MI, because they may not know what you're talking about. Have you ever had a heart attack? And say, no, never had a heart attack. No, never have. No, never have. And you look on their EKG and it shows that they've had an old MI. And you say, have you ever had problems with really bad indigestion? Oh my goodness. My wife and I went to Long John Silver 6 months ago and we had the fish. I had indigestion for 4 days. Haven't been back there since. He didn't have an indigestion. He had an MI. He just wasn't smart enough to figure out he was having an MI or fast enough to get himself to a hospital. So he happened to survive one that didn't get diagnosed. Doesn't mean he didn't have it, and it doesn't mean he doesn't have the damage. It just means he doesn't know it. The other thing to keep in mind is there's a whole lot of patients who don't have a clue, like my mom. And it's not that they're not smart. My mother's a very intelligent woman, but she just doesn't keep track of that stuff. So when you say things to them like, have you ever had any kind of medical problems? No. Do you take any medicine every day? Uh-huh. What do you take? Insulin. Didn't you just tell me you didn't have any medical problems? Well, honey, if I watch what I eat and I take my insulin, it's not a problem. Do you take any medicine every day? Uh-huh. What do you take? Ask my daughter. Ask my wife. Ask my doctor. It's in my record. Ask my dog. Or they're the rainbow people. I take a green one, a pink one, a red one, a little tiny white one, a big fat white one, and a purpley triangle one. Yep. Well, thank you for narrowing it down for me. What do you take it for? Because the doctor said to. Or you have the people that come in with the Winn-Dixie bag or the shoebox. And in that Winn-Dixie bag or shoebox, they have every prescription bottle they have ever had filled since 1951. And you get to play Vanna White. Do you take this one? No. You take this one? No. You take this one? Oh, yeah, I take that one. I take it 3 times a day like it says on the label. Oh, no. I know I can't take it 3 times. It makes me pee. So how often do you take it? Oh, I just take it in the morning. Does your doctor know you're only taking it once a day? Oh, no. He'd get mad. So trust me, one of the things you have to become very skilled at as a nurse is making sure you're asking the right questions. So I don't ask people anymore if they have medical problems. I say, do you have any kind of medical condition for which you are currently being treated or should be seeing a doctor for? Because sometimes if you say, are you being treated? They say, because they're not seeing anybody. It's one of those times you get to go into the lounge, hit your head against the wall 3 times and say, help me, Lord. God grant me patience, and I want it right now. So when we're looking at the EKG paper, we're looking at measurements of time, and for all intents and purposes, when you're looking at rhythm, you are looking at the timeline. We're not as concerned about voltage when we're just trying to identify a rhythm. We get a lot more concerned about voltage when we're trying to look for things like patterns of ischemia or old infarctions or maybe new infarctions. We start looking at at whether or not they've got little tiny complexes or big complexes. We're looking to see if their complexes are normal size in comparison to the other leaves, or whether they're shrunk down. So that axis becomes a little more important for that. But for today, we're primarily focusing on the horizontal axis. So what do we have? We have waveforms that are generated onto the paper. And the waveforms include the P wave, the PR interval, the QRS, the ST segment, and the T wave. So let me talk about each one individually. The P wave, for all intents and purposes, represents the depolarization of the atria. It is all those atrial cells getting ready to squeeze. So that if I had all of you stand up and I said, okay, on the count of 3, I want you to jump as high as you can off the floor. By the time I got to somewhere between 2 and 3, you'd be flexing your knees, tightening your quads, tightening your glutes, getting all ready, getting your hamstrings ready. And when I said 3, you'd push off the floor with all those muscles nice and tight to try to give you as much lift as possible. Well, your heart does the same thing. It has to get ready to contract. And that getting ready phase is what we call depolarization. And it's represented by the P wave. Now, it's not like the EKG machine looks through your chest and says, it's getting ready, get ready. Okay, it's getting ready. What it does is it actually records the movement of sodium, potassium, and calcium ions in and out of the cell. And that fluxing in and out of the cell creates an electronic ionic change, and that's what gets recorded on the paper. So when things that were inside the cell move outside the cell, and when things that were outside the cell flux inside the cell, that's what causes that depolarization. And when it's the atria are thin walls, small chambers, so they don't make a big bump. They make a nice bump, a little bump. It's like a meeting. Okay? Now, the distance from the P wave, which is that first positive deflection off of the isoelectric line, to the beginning of the QRS is called the PR interval. That not only represents the depolarization of the atria, but it also represents movement through the AV node. So if for whatever reason I have a delay in conduction through the AV node, what's going to elongate is going to be my PR interval. And the big thing that you're looking for when you're trying to do rhythm identification is you look at it and say, is it normal? So if I know that the normal PR interval is supposed to be somewhere between 3 baby boxes and 5 baby boxes, 0.12 seconds to 0.20 seconds, and it is longer than that, that tells me that there's a delay getting through the AV node. He stopped to check somebody's ID. Okay? If it's within that normal time frame, I'm good. My conduction through the AV node is just fine. Thank you very much. Okay? Now, the next thing that happens after my atria depolarize is my ventricles need to depolarize. So my impulse has gotten to the AV node, and it's going down the ventricular conduction system, down the bundle of His, bundle branches into the Purkinje fibers. That's depolarization of the ventricles. The ventricles are much thicker muscles. So if you get the ionic changes that are going on through those muscle fibers, you got more muscle fibers, you're going to make a bigger bump. And the bump that it makes is called a QRS. That represents depolarization of the ventricles. After that, the next bump you see is the T wave, and that represents repolarization of the ventricles. And the easy way to think of repolarization is we're going to go back to having you jump again. Once you have jumped off the floor and gotten as high as you can get, what are you going to do? You're going to come back down. I hope you're going to come back down. If you don't come back down, I'd like to have a talk with you after class. But if I said to you, as soon as you hit the floor, I want you to jump again. Coming back down, getting your feet set on the ground again is like the repolarization. It's returning to your original position from which you can take off again. In this case, it's taking a heart that has depolarized, your ventricles have depolarized, and hopefully what's occurred after depolarization is squeeze. Now your heart is all squeezed down, and it has to return to rest in order to be able to charge again, to go again, because as far as I can tell, you wouldn't do well if you only had one heartbeat. You got to have them in a row, don't you? So the thing that allows you to do that is this process of depolarization and repolarization. An easy way to visualize it, if you can visualize standing on the shore and you've got waves that are coming up to cover your feet, and then they recede back out into the ocean, and then they come up again. It's that constant ebb and flow. It's that depolarization and repolarization, so you can get another wave. Depolarization and repolarization. Now, for those of you who are paying particular attention, you might be saying, wait un momentito. You mentioned the depolarization of the atria, but you didn't say anything about repolarization of the atria. Well, that's because the repolarization of the atria happens at the same time the depolarization of the ventricles happens. And because the wave is smaller, you don't see it. It's there. You just can't see it. Trust me, I promise. It's there. So that what you should have in a normal cardiac rhythm is depolarization of the atria, followed by depolarization of the ventricle, followed by repolarization of the ventricle, followed by depolarization of the atria, depolarization of the ventricle, repolarization, and it should run in a nice little cycle. And if the impulses are being initiated in your SA node, it's going to occur normally 60 to 100 times a minute. Does that make sense? Okay. Let us move on. Okay, now just in case you didn't quite get that, I wrote it down for you. So that the P wave represents the depolarization of the atria, the QRS represents the depolarization of the ventricles, the T waves represent the repolarization of the ventricles. Now, there's an extra little bump that sometimes will show up. It's usually very little, and most people don't pay any attention to it. It's called a U wave. One of the things that's happened is, in my day, we had EKG machines that were not sensitive enough to pick up a U wave unless there was a problem with it. Nowadays, we have machines that are extremely sensitive, so we're now starting to see it more often in patients. There's actually a theory that's been put forth that says that the U waves probably, unless they are enlarged, are simply representing the repolarization of the Purkinje fibers themselves, that tail end of the ventricular system. Nothing to worry about, just kind of there. But I wrote it down just in case. So, here's the deal. I can tell you that the very first time I went into the hospital and they said, I want you to go in and do an H&P and an assessment on this patient. And I went back and finished up after lunch because I really didn't have a system. And as you start to develop a system of how you're going to assess patients or how you're going to approach them or what kind of questions you're going to ask, you're going to find that you will fall into kind of a similar pattern of asking questions, of going in and doing your assessment, of going in and getting, history information on them. And so part of it is having a system that allows you to become fast enough that in a lot of instances, once you get to be experienced, you can go in most patients and do an initial assessment in history in probably 5 to 10 minutes versus 4 to 5 hours. Trust me, it takes a little time. I have news for you. My first job out of nursing school, I went to work at an 1,100-bed teaching hospital in downtown Detroit. And the first week, they assigned me a CNA role so that I could get to know the unit and get to know the people. And I thought, woohoo, yay, all I got to do is beds and deaths and Bible science. Whoop-de-doo. And it's like almost lunchtime, and I'm finished. I got my second patient. And I walked out of the room, and there's a little lady who was 4'10" on a good day, who was probably 109 years old, who had been at that hospital literally since it had been built in the 20s. Her name was Carrie Knight, and she was a CNA. And I walked out of the room, and she's leaning against a wall with her arms crossed across her body, and she's doing this. And I'm like, what? She said, honey, you better get it together, or nobody's going to get bathed till midnight. And she had apparently watched me do this thing where I took my linens down to the room and realized I didn't have enough washcloths. So I went back to the linen cart and got more washcloths and brought them back to the room. Then I realized I didn't have any soap, so I went and got soap. Then I realized I didn't have any lotion, so I went and got lotion. Then I realized I had a male patient and he needed to be shaved, so I went and got shaving cream. Oops, forgot the razor, went and got the razor. And she'd watch me do this. Like I was a carnival bear or something. And she just finally decided, oh, this child needs some organizational skills. And I learned more from her in 6 days than I had in half my life because she had a system. So this is my system for looking at EKGs. The very first thing that I look at when I look at an EKG is I look at rate. So how do I calculate rate? Well, there's a couple of different ways that you can do it. EKG paper has a hash mark on the top. Then it has another hash mark about 3 seconds later, exactly 3 seconds later, and then another hash mark 3 seconds after that. So if I count the total number of complexes from hash mark number 1 to hash mark number 3, I have a 6-second strip. So how many 6-second strips do I have in a minute? 10. So if I count the number of total complexes and multiply it by 10, I have a rough estimate as to what my heart rate is. Is it exact? No. Is it close enough for government work? Nuh-huh. Now, the big thing you have to understand is that if you're counting it, you have to have full complexes. So, if you look at my top example, see where my red line is? My P wave for that complex is on the wrong side of the line. So if I'm using the scan method, I shouldn't count that complex. On the other end, you'll notice that the T wave of that complex is on the wrong side of the line. So I shouldn't count that one. I should only count the ones in between. And for those of you who are doing the one, there's 12.
Yes.
So if I have 12 complete complexes in that 6 seconds, and I multiply that by 10, my heart rate is 120. If I had 7, my heart rate would be 70. If I had 3, my heart would be whoops. It would be 30, and oh my God, it's 30. Okay? You'll find that there are certain rhythms that will not just be a number. It will be a comment as well. What's his heart rate? Oh my God, it's 20. You'll never hear anyone say, oh, his heart rate is 20. It will be, oh my God, his heart rate is 20. You won't hear anyone say, oh, his heart rate is 240. It'll be, holy moly, it's 40. 240. So sometimes you get a comment along with it. Okay, so that's the scan method. I will tell you 99% of the time when people are doing rhythm calculations or rate calculations, that's how they do it, is using the scan method. Because you can do it for rhythms that are regular, you can do it for rhythms that are irregular because it's just an approximation. For those of you that are obsessive, compulsive, anal retentive, you have suspenders and belts. There's also a method you can do that's called the calculation method. The calculation method is you take an R wave, you count the number of little tiny baby boxes from one R wave to the next R wave, and divide that into 1,500. And it will give you an exact amount. It will tell you that it's 74. I'm happy with 70, thank you. And the thing about calculation method is you can only use the calculation method if the rhythm is regular. If it's irregular, you can't use it. And I have to tell you, I multiply by 10 a whole lot better than I divide into 1,500, so I use the scan method.
Yeah.
The next thing I'm going to look at is I'm going to look at rhythm. I want to see, is it regular or irregular? How do you determine that? You measure from R to R. If the R to R intervals are regular, like this one is, they're all the same, then your rhythm is regular. If it's like the top one, where you have a short one and a long one and a medium-sized one and a long one and a short one and a long one, you got them all over the place, that's irregular. And the reason why that's important is because there are certain heart rhythms that are always irregular. And there are other rhythms that are always regular. So if I have a heart rhythm that is always regular, and my rhythm that I'm looking at is irregular, I can say, okay, it's not that. I have to look at the ones that are irregular. One of the ways of narrowing it down. The next thing I'm going to look at is I'm going to look at the presence of P waves. And there's 4 different things I want to know about the P waves. The first thing I want to know is, do I have them? Because there are 4 rhythms where you don't have P waves. So guess what? If I'm looking at a rhythm strip and there are no discernible P waves, I'm now down to 4 choices. That's a whole lot better than 38. Okay? If, however, I have P waves, I have another question, and that is, are my P waves upright or inverted? And here's the deal. whenever electrical current is flowing toward a positive electrode, it makes your waveform go above the line. So it's called a positive deflection. So if I'm throwing a ball to you and somebody were charting the arc, it would say, ta-da, there's the arc. And it went from me to you, from the SA node to the AV node. I'm a happy camper. That's the way it's supposed to go. If, however, and so in those cases, whenever it's being generated from above the ventricles, specifically from the SA node or high up in the atria, my P waves are going to be upright. Okay? If, on the other hand, you were throwing it to me, the AV node was initiating the impulse, and it's going to send it down the ventricles in the opposite direction, but it has to depolarize opposite from the pathway it normally does. You're sending your electrical energy toward me, and the positive electrode is in that back corner. Now I'm going away from that positive electrode instead of toward it. So if when I go toward it, I make the bump go above the line, what do you think happens if I'm going away from it? I make the bump go below the line. So whenever you have an inverted P wave, that tells you something right away. So the first thing you want to know is, do you have them? The second thing you want to know is, are they upright or inverted? Then the next thing you want to know is, do they all look the same? Are they the same shape, the same size, and the same deflection? Because here's the deal. If I handed you all a plate of cookies, and every single cookie on that plate was a reindeer, what kind of cookie cutter do I have? I have a reindeer. So if they're all upright, the same shape, the same size, they're coming from the same place. And where's the most likely place? The SA node, because that's your natural pacemaker. If, however, my P waves are different shapes and different sizes, I got a reindeer, a snowman, a witch, a ghost, a star, a Christmas tree, an Easter bunny, and a pumpkin, that means it's coming from a whole lot of different places. So if my P waves are different shapes, different sizes, different deflections, means they're coming from different places. So it's not all coming from the SA node. Okay, does that make sense? Alrighty. Last thing you need to know when you're looking at P waves is, does every single P wave have its own QRS? This is a dance that's supposed to happen. When they come to the party, she is supposed to bring he. If she shows up and she don't got a he, she could mess with the other he's. So if you've got more P waves than you have QRSs, that means something happened and that impulse that got transmitted didn't make it through the AV node. The AV node said, nope, can't come through. So there was no ventricular depolarization in response to that atrial depolarization. You got P waves that stand alone. And we'll talk about heart blocks in just a little bit. But basically what you're asking yourself is, do I have them? Are they upright or inverted? Do they all look the same? And do they all have a QRS with them? Then the next thing you're going to look at is the PR interval. And you're going to measure the PR interval from the beginning of the P wave to the beginning of the R wave. And specifically what you're looking at is my PR interval normal? Because if my PR interval is normal, that means the complexes or the electrical charges are making it through on time, just like they're supposed to. The doorman's opening the door and letting them through. Go on through. Go on through. Go on through. And in response, the ventricles depolarize because they've gotten that electrical charge that's come through that AV node. So now you get the ventricular depolarization. If the AV node stops it and won't let it through, then you don't get any ventricular depolarization, so you don't get a QRS. You have a P wave because your atria depolarized, but you don't have a QRS because your ventricles didn't. So if you've got a P wave followed by a QRS, and it's within a normal time frame, that tells me that not only did it go through, but it went through just like it was supposed to. If you think about that AV node like a revolving door, and every time an impulse hits it, it goes through, goes through, goes through. Now I got little rotten kids that are throwing gummy bears in the track. So the first guy goes through, the next guy goes, yeah. Yeah. No, forget it. Okay? Think about it that way. How hard is it to get through? And if it's they're all going through right in the normal time frame, I'm good. My atrial to ventricular conduction is normal. Okay? Now, the next thing I look at is my QRS. Is it normal in size? And it should be really tight and narrow. It's somewhere between 0.04 and 0.10 seconds. In fact, the most recent literature now is talking about 0.09 seconds. I have enough trouble seeing half of a baby box. I don't think I can see a quarter of a baby box. Give me a break. Okay? But we're talking about 1 to 2.5 boxes. That's the width of your QRS if your ventricular conduction is normal. Now, let's say that my ventricular conduction is getting ready to go down. And remember, we talked about the ventricular conduction like a slide of Wet n Wild. So the door opens and you go down the main chamber and you can go off to the left or off to the right. And you veer off to the right. And about halfway down that right side of the slide, there is a fat kid stuck in the slide. There you are. Now what? Can you get to the pool at the end of the slide if there's a fat kid stuck in the thing? No. Bundle branch block. So how do I get down to the pool? I have to go cell to cell to cell to cell to cell. They got a wheel and a staircase, and I got to walk down step by step by step. So if you were measuring the amount of time it took me to get down into that water, if my slide is open, it's... But if I got to go cell to cell to cell, what happens to the size of my QRS? It widens. So whenever you're looking at a QRS, and the first thing you notice when you pick up the rhythm strip is your QRSs are nice and tight and narrow, what can your brain say immediately? My ventricular conduction is good. If I pick up a rhythm strip and my QRSs are big and fat and wide, then there's a problem with my conduction. Make sense? Okay. Those 5 steps in and of themselves, rate, rhythm, P waves, PRM, and QRS, is really all you need to identify a rhythm. But I like to add a little icing on the cake and a little rosette here or there. So I also look at things like the ST segment. I look to see if the ST segment is normal, meaning it comes back up to the isoelectric line nice and quickly, or is it depressed, or is it elevated? Let me show you what I mean. See my little depressed STs? And the easiest way to think about this is they don't have enough oxygen to get all the way back up to the isoelectric line. They're ischemic. I'm depressed. I'll feel better later. In some cases, this is your isoelectric line, that point at which there's no electrical activity. So if I lay a card across here, look at how low that ST segment is. Depressed ST segments may well be an indication that you have an ischemic event going on, especially if you have ischemia in specific leads that look at a specific wall of the heart. And that's basic 12 leads. And when you come to work for us at Leesburg, you can come to one of my classes and I will teach you that. That's a tease. The other thing that can happen, there's your isoelectric lines. Now, by the way, just let me let you know, if you want to draw on it, you need to run your own strip. They don't like you drawing on the ones that go in the chart. It really ticks people off. I will also give you a major warning, okay? And that is this. Most hospitals that you work in will be very encouraging when it comes to helping you learn. But if you are going to run 12 lead EKGs to take home and play with, or rhythm strips to take home and play with, Most facilities do not have a problem with you doing that. But before your shiny little feet exit the building, any patient information must, emphasize the word must, be removed. And I don't mean magic markered. Oh, I'll just flat it up here. Nobody will know who this is. Nuh-uh. I mean cut off. Because if you take something out of the hospital, take it home and play with it, throw it in your trash, and somebody finds it, and it says on it, Central Florida Health Alliance, Mr. John Smith, room ICU 4, 199076293, birth date 11/26/49. Trust me, they will track us down, and they will try to find out who did that. And if they find it in your trash, we are talking up to $50,000 fine per incident for the hospital and a $25,000 fine for you. Not to mention, if you're already working at the hospital, that's grounds for immediate termination. That's a HIPAA violation. So, I'm not saying don't learn from us, because we're happy to teach you, but you cannot take any kind of patient information out of the hospital. It's an absolute no-no. Okay? So I'm done with my scaring you to death. Here's my ST elevations. If you have a QRS that is an upward deflection, you get this little thing that kind of looks like the sideways view of a fireman's helmet. Let's see if I did my lines. If I have a QRS that's a downward deflection, I have a QRS that looks like a tombstone. And in fact, that's what nurses call them, tombstones. Normally, ST segment elevations are an indication of an acute injury that's happening right now. If I have ST segment elevations in leads 2, 3, and AVF, I can look at a PG and I can pick up the phone and call the doctor and say, Mr. Jones started having chest pain. We ran a 12 lead. He's got ST elevations in his inferior leads. Looks like he's having an inferior wall MI. Want me to send him to the cath lab? Now. Thank you very much. Want me to get some labs? Yeah. Want me to start some nitro? Oh, yeah. Want me to do stuff? Yeah. Okay. And I will tell you something. One of the things that has changed since I started in nursing school is that we now have physicians who think of us as colleagues. We're not just the chart carrying, bedpan carrying, med pushing, water getting kind of. They think of us as colleagues. If you speak to them as colleagues, Mr. Jones was having chest pain. Did you run a 12 lead? What does it show? I don't know. I don't read 12 leads. It's got really funny wiggles and squiggles on it. You want me to fax it to you? Guess what he thinks? Well, there's an idiot. And you know what? If you're working on a cardiac medical floor, an IMC, or an ICU, I'm going to think you're an idiot too. Because it's part of your responsibility to learn how to do the stuff you got to do. And guess what? Reading 12 leads is easy. There's a lot of nurses that are like, oh, Lord, help me now. But it's really easy. Trust me. Take my class. You'll find out. So do you have ST depression? Do you have ST elevation, or are they normal? And then last but not least is looking at your T waves. And you're looking to see, are your T waves normal? Are they high and pointy and peaked, or are they flat? Because high pointed peaked T waves can be an indication of hyperkalemia, too much potassium. They also can sometimes be an indication of a drug toxicity. But most of the time when you see high pointy peaked T waves like that top guy, that's usually an indication of a high potassium. Really flat, squatty looking T waves may be an indication of low potassium. Deb, are they far enough along in their program to know what kind of patients would have high and which would have low?
We just went over electrolytes.
Okay. And they're like, oh, God, I didn't think she was going to ask questions. It's real simple. If you think about it, there are certain kind of patients you're going to run into that you would expect to see a high potassium. Renal patients, for example, they don't filter their potassium. So they live in the land of hyperkalemia. They're normally at 6, 6.5, 7, 7.5. I had one guy that had a 9. And I went and got the book and said, excuse me, according to the book, you should be dead. And the guy said, well, aren't I fooling somebody? I said, just lay down and be quiet for a while till we get you to dialysis. He had missed 3 dialysis treatments and had fluid up to here and a potassium of 9. He said, and his whole thing was, didn't have a ride. Well, if you stayed in your house another few hours, I can guarantee you'd have a ride. It wouldn't be to dialysis, but you'd have a ride. So you look at that for that. The other thing you look at are what are called inverted T waves. Now, I want to tell you that inverted is a misnomer, and let me explain why. The vast majority of people, when we first started doing EKGs, would monitor patients in what's called a lead 2. And they monitored them in that lead because the positive electrode was down here and all the electrical current normally flowed toward that positive electrode. So all of your little waveforms were upright. Your P wave was up, your QRS was up, your T wave was up, and everybody was a happy camper. The problem is a lead 2 may not necessarily be the best lead in which to monitor patients. So as we became more enlightened about it, we started monitoring in patients in what was called a modified chest lead 1, or some people call it a V1 lead, where the sticky is here, that's the positive electrode, but the negative pole is like in the very center of the heart. Okay? So it's not like a bipolar lead where you have a negative sticky and a positive sticky. It was... Hello? No, don't. No.
Cancel.
Help. Make it not do that. Cancel. Thank you very much. Okay.
Probably when you get to a point, they might want to run to the bathroom for 5 minutes.
Okay. So the idea here is when you're looking at this, the T wave should go in the same direction as your QRS. So if your QRS goes up, your T wave should go up. If your QRS goes down, your T wave will go down. But if you've got your QRS going in one direction and your T wave going in another, that may be an indication of ischemia. Emphasis on the word may. And the reason for that is this. Sometimes when patients have big MIs, they will flip their T waves as part of their MI process. And when they're done and their MI resolves, the T waves say, I'm not going back up. He's just going to do this again in 6 months, so I'm just going to stay down. Which is why if you've ever been in an environment and you hear a doctor yelling, I need to see an old EKG, I need to see an old EKG. One of the reasons he may be looking for an old EKG is he wants to see whether or not these inverted T waves are new or old. Because if they're old, don't care. If they're new, woohoo! Okay? So that essentially is the process of looking at an EKG. Rate, rhythm, P waves, PR intervals, QRSs, ST segments, and T waves. And by that time, you'll know. I promise. Okay? Take a quick 5. And then we're going to actually start looking at rhythms. See if you need to charge your batteries or flip the things or
Okay, quick thing.
put it on hold for a second.
Can I get you a water or?
Yeah, water would be great.
Okay.
You have
I'll
one.
grab you one. I wonder if I should.
You need money, honey?
No, I got it. I wonder if I should start over with this on our break from here. We'll start
See, this
again.
would be entirely too much for me to figure out.
I know exactly, Mama. Where am I now? Oh, I don't want. Duh. That's why I couldn't do it.
You're moving.
I'm